Hey, good morning, and welcome to the UroPatient podcast. I'm your host, Vic Sinise. Welcome to the show. We meet here every Saturday at 10:30 a.m. And if you're watching us live on YouTube or Facebook, glad to have you on board. You can learn more about the show by visiting us at UroPatient.com, the best place to go to learn more about our show. Also, you can find all of our past episodes. Remember, this was created for you, the patient out there. I also created all these helpful handouts. Every time I have an episode, I've got a handout to go along with those episodes. You'll find them helpful. Check them out at any time. They're there for you guys. So today we're going to talk about vasectomies. And I've got a good friend of mine, Dr. John Lynn, urologist out of Arizona, who's going to talk to you about vasectomies. He's the #1 vasectomist over in Arizona. So John, take it away.
So vasectomy is a way for you to engage in worry-free sex with your partner. If you're done having kids, or if you never had any children and having children is not in the cards for you, and you are absolutely sure that you don't want to have more kids, then vasectomy is the way to go. Let's talk about efficiency or efficacy, effectiveness of vasectomy. Vasectomy is performed about 500,000 times annually just in the US alone. When it comes to effectiveness in preventing pregnancies, short of not having sex, short of abstinence, it is the most effective way to prevent pregnancies. Vasectomy is 99.95% effective. Failure rate of 1 in 2,000 is extremely, extremely effective. Sometimes, you want to make sure that you are completely done having kids, because it is a permanent form of sterilization. It is not something where you can just say, well, I changed my mind. Can I go back? It's going to be difficult. 99.95% effective. Now, that said, it is not a way to avoid sexually transmitted infections. It only prevents pregnancies, but it does not prevent you from catching something bad if you are indiscriminate, shall we say. All right. How the procedure is done and the experience of the patient and how long it takes, as we already found out, it depends on the experience of the surgeon. I will tell you that when I first started doing vasectomies, I sucked at it. During training, nobody wanted to do vasectomies because there's a small case. We didn't concentrate on vasectomies. But then when I came into private practice, a lot of people wanted vasectomy. So I remember my first vasectomy, it took me 30 minutes. I was literally sweating. I made 2 incisions, and I was wearing these big magnifying glasses to perform the procedure. Now it is so much better because of experience. So your mileage will vary depending on the experience of the surgeon, experience of the staff, and how the procedure is performed, how long it took, and also the patient experience. Not all physicians do it the same way. And according to the 2012 updated 2015 AUA guidelines regarding vasectomies, the surgeon or the urologist, typically the urologist, should do the method that gives the best patient outcomes and the best patient experience. When it comes to patient selection, it is important to let the patients know that this is a permanent sterilization procedure. If the patient comes in and he starts talking about reversal or sperm banking, I try extra hard to talk him out of it. It seems like if they're thinking about going back or changing the sterilization so that they can have kids again, then are they really sure that they want to have a permanent sterilization procedure? So in that situation, I try to talk them out of it. And I saw someone mention that if there's a age limit under which or above which I do not perform a vasectomy. Well, I'll tell you, I have patients in the 70s coming in for a vasectomy, and someone as young as 18 coming in for a vasectomy. Some men are just absolutely sure that they do not want to have kids. And I do not discriminate based on age. So I'm age agnostic. If I try my darndest, even for that young patient, I try to tell them, hey, you know what? When you're 14 years old, just think about what you thought you knew. And now think about when you're 21 or you're 18, how things have changed. How do you know after you make this permanent life-changing decision that you're not going to change your mind in the future? So I try everything I can to talk them out of a permanent sterilization procedure. But if they're dead set on having it done, then I'm not going to prevent them from doing it. I also do not obtain spousal consent. I don't ask the wife whether or not the man should have or can have a vasectomy. Likewise, a woman does not require a male's consent to achieve sterilization to obtain tubal ligation, the female equivalent of a male vasectomy. So I do not obtain consent from the opposite partner, if you will. All right, when it comes to vasectomies, some people have said, I can do it virtually, seeing that patient the first time via telemedicine and not seeing the patient in person. My bias is that I want to see the patient in person. I want to meet the patient. Yes, there's a lot of social media content out there about my vasectomies, but there's nothing better than physically seeing the patient and establishing that know, like, and trust factor. Yes, the patient's already there for undesired fertility, for me to talk about other techniques to avoid pregnancy, and then ultimately us deciding on a vasectomy. But I want to make sure, I want to be able to see the patient. I want to be able to gauge or judge his vibe, if you will, because that is extremely important. I think of it as kind of like dating. That initial, you want to set the expectations. You want to make sure that they know what to expect from the experience and the long-term consequences. So I try to make sure that I see the patient in person at that first meeting in real life and not do it virtually. In addition, getting accurate history from the patient is also very important. I want to make sure that this patient tells me about their past surgical history. Have they had an orchidopexy? Have they had a hydrocolectomy, spermatocolectomy? Did they have an undescended testis that they require surgery? Did they have prior trauma to the scrotum? Or have they had a prior vasectomy and then a subsequent reversal, and now they want a vasectomy? So these are all important histories for me to obtain, because that tells me, okay, what am I going to get when I finally examine the scrotum? Also, there's some guys who are extremely anxious. They come in, they show up, you can just sense their anxiety. Those patients, I want to be extra careful. I want to talk about various different ways of anesthesia. We'll talk about that in a second. So I want to make sure that they can tolerate the procedure. Even though technically I can do the procedure, I want to make sure they have a great experience. So making sure that they can tolerate the procedure is another reason that I see the patient. It's in person, because it's difficult through a camera to judge how the patient is going to respond on the day of the procedure. But in person, it's really easy to figure that out. When the patient comes in initially, before I even see the patient, my amazing medical assistants have already gotten vital signs on this patient. I can't tell you how many men, how many young guys, typical age of vasectomy patients, about mid-30s. I have diagnosed so many guys with uncontrolled, undiagnosed, asymptomatic hypertension. And that is why they call this a silent killer. Nothing happens to him until one day, stroke, heart attack, and they check out. Well, I can't have him do that. This is a young guy who's productive in society, who has a family, typically kids that he has to support, and also a wife who's a companion, and maybe they support each other in today's day and age, right? Not just the man supports the wife. The wife sometimes works as well. But I need to make sure that I do everything I can to preserve that nuclear family, to make sure that he's working. In addition, I jokingly tell the patients, I need you to continue to work so that you can pay into my retirement, right? When I finally retire. Being able to examine the patient, being able to make sure that there are actually two vas deferens, two vasa, one on each side, is important. Sometimes there's a congenital absence of vas deferens. when I examine the patient. So if that's the case, then I need to know beforehand and let the patients know. If the patient has a tight scrotum or it's difficult to isolate the vas deferens, then I let them know that I may struggle a little bit. Even despite my vast experience, you may feel a little bit more pressure and a little bit more tugging during the procedure. So I want to set the expectations at the very outset before the day of the procedure. All right, let's talk about technique, how the procedure is done. Now, again, it varies by surgeon. It varies by the urologist. Even though I can say that I performed a no scalpel technique, some urologists use a scalpel. Some urologists make 2 openings in the scrotum to perform the procedure. I make a single puncture without using a scalpel. So your mileage will vary depending on the comfort level of the surgeon in performing a certain technique versus someone else. And I will tell you, when it comes to vasectomies or any surgery for that matter, experience means a lot. Experience of the surgeon matters a lot. But the way I perform vasectomies is that the patient's lying on his back. And I think that's mostly how most urologists perform vasectomy, is the patient lying flat on his back. I don't know where some of the patients get this information, but there's no laser involved when it comes to vasectomies. I'm not aware of a way of how laser is in any way involved in the performance of vasectomies. So no laser involved in vasectomies. Ah, yes, manscaping. This is something that sometimes is feared, and it's a big worry, believe it or not, for some of my men. Now, a lot of you guys and gals may be thinking, oh my gosh, are you kidding me? Everyone I know manscapes. Well, not all of them do. When you've examined as many scrotums as I have, I will tell you not everyone manscapes. I tell my patients manscaping could be done with a sideburn trimmer, with scissors, or with razor, however you want to do it. But you do not want to use epilation. You do not want to use Nair. You don't need to have your hair follicles lasered off, even though I have seen guys who have had cosmetic laser surgery on their scrotums, not for vasectomy, but they've had their hair removed permanently using laser. You don't need to go overboard when it comes to manscaping. You can just use shears, scissors, something simple, nothing fancy. And my staff, they're so smart, because when someone does a manscape and they show up for their vasectomy, even despite the fact that we have it on a handout, if they don't manscape and they show up, then we have to do it. And it's definitely not as comfortable as possible. We jokingly tell the patients that if you make us do it, we're going to charge you extra. But on a handout that we give our patients, we highlight the area where we remind them that they have to shave and make sure that they show up cleanly shaven. All right. When it comes to anesthesia, so many different ways to make sure that the patient has the best experience possible. It doesn't matter how we do it. Verbal anesthesia. Everyone gets verbal anesthesia, meaning conversation if they wish, or I have a conversation with my medical assistant during the procedure. Everyone gets local anesthetic in addition to verbal anesthesia. So they get numbing medication and they get conversation. And then after that, there's a variety of ways to make sure the patient's comfortable. It could range from nothing, absolutely nothing at all, to oral Valium, to nitrous oxide or laughing gas, to the very anxious patient who needs IV sedation. In Arizona, I have the luxury of having an anesthesiologist come into my office and then starting an IV on the patient, putting the patient under twilight, if you will, and then performing the procedure in just a few minutes. That's for the very anxious patient who has to lay down on the floor, believe it or not, or lie down on the table immediately after I examine the patient. These are the super anxious guys for whom I offer IV sedation in the office. And then for the difficult anatomy, someone with previous surgery, I know it's going to be a struggle. General anesthesia is also offered so that he has the best experience with the best outcome possible. All right, when it comes to instruments, this is all I use. 6 pieces of instruments, not including the suture, not including the local anesthetic. The blue instruments, other than the one on the left side, the blue instruments are all made of titanium. Very strong metal that is also very lightweight. All right, this is going to be a short video of a vasectomy that I performed about a year ago. This video is being played back at 2x the speed because I don't want to belabor the point. I'm going to kind of briefly narrate the right side of vasectomy. The right vas deferens is initially palpated. I try to isolate the vas, and that's the most difficult part of the procedure, is finding the vas deferens. I tell patients that this is all by feel, and that's why I don't think a robot will ever replace a vasectomy procedure. A robot can never perform this autonomously because you have to manually find it, and not everyone has the same anatomy. I'm giving infiltrating local anesthetic right here, and I use a 26 gauge needle. Only a total of 2 to 3 cc's is needed. I use the vasectomy dissector to make a single puncture around the vas deferens. With my left hand, I'm isolating the vas, and then this is the ring clamp that I use to capture the vas. And with my left hand, I confirm that I actually have the vas. And if you notice, the instruments are being passed to me. My eyes almost never are off where I'm operating, and that's how I'm able to do this so efficiently. And the little dissection, now I have the loop of vas isolated, dissect the external spermatic fascia off the vas deferens, the blood vessels underneath. I use the bipolar cautery to divide and cauterize the ends of the vas deferens. And I can use the same cautery to stop any sort of ooze. And then I use a piece of suture to perform what's called fascial interposition. I use the patient's own tissue to cover up the abdominal end of the vas deferens. And keep in mind, this is being played back at 2x the speed, just to make sure that we get through everything. So the typical procedure takes me less than 5 minutes. Even though on a handout that I give to the patients, I tell the patients that it's going to take less than 10 minutes, but I like to under-promise and over-deliver. After the vasectomy, the recovery varies by individual. We tell the patients, don't shower the first day, and no soaking the wound. You want to pat dry. You may resume protected sexual activity about a week after the procedure. And for my patients who are white-collar workers, I tell them a day and a half, you can get back to work. For my folks who work from home, I tell him that you can go back to work the same day, because you can be in a Zoom meeting. I say that you could be having a party up top. I'm sorry, a business up top and party down below. You can be applying ice. You can be wearing scrotal support. Nobody is the wiser when it comes to your recovery if you work from home. And for my construction workers, police officers, firefighters, UPS delivery folks, I tell him that you want to take about 3 to 4 days off. And we tell the patients that you want to listen to your body. Even though these are, we tell you a day and a half, 3 days, 4 days, 7 days, listen to your body. If your body is saying that you can't tolerate it, or if you're feeling a little unease, a little bit of pressure, then obviously don't go overboard. We also caution patients that you're going to feel great most likely right after the procedure. Don't overdo it. All right. You want to kind of listen. Those who follow our instructions and they follow our directions, they do great. But I've also had patients who had a vasectomy, and the next day they go to the lake and they soak the wound in the lake, and they call us wondering, gee, it's all red and swollen. I wonder why. So be smart about it. After the vasectomy, we tell the patients that you are absolutely not yet sterile until a semen analysis that is done 3 months and 30 ejaculations later, showing no sperm. And of course, we have to talk about the rare complications after vasectomy. Recanalization or reconnection of the tubes is a possibility. Chronic pain occurs in 1-2% at the very most. Thankfully, in my hands, it's less than 1%. So anytime you do any sort of procedure, there's always a remote risk of complications, and infection is one of them. And it can be devastating in this situation. Hematoma, having a little bit of blood collection in the scrotum after the procedure, is a possibility. Sperm granuloma, having a little swelling, a tiny little scar area in the area of the vasectomy. Sperm granuloma is also a concern.
Hey, thanks, John. That was really great. I really appreciated you doing that for me. And we'll see everybody next week on the UroPatient podcast. Have a great weekend, everyone.